Yes.
Okay, I just need to make sure. Thank you. All right, so let's talk about Chapter 32. Again, I mentioned a lot of this when we were reviewing the presentation by the group of students, but just as a reminder, I just want to make sure that you're aware of some of these definitions. Of course, ADLs, we're going to talk about that in a little bit more detail shortly. Frailty, uh, just remember that frailty also includes like a progressive weight loss, slow walking speed, low grit strength, low activities level, and also fatigue. So it is a person who has poor endurance and weakness, but it gives you a little bit more uh, definition, the one that I just gave you. Progressive weight loss, they're just frail, right? And the other important term here for today is the IADLs, the instrumental activities of daily living. Important to know, and we're going to look at those as well. So just a couple of terms on here, actually 3 terms that I want to make sure that you're familiar with those terms. Okay. As far as these, there is a difference between rehabilitative care and restorative care. Right, rehabilitative, we want to return the patient to their previous level of function for rehabilitative care. For restorative care, we want to maintain or maybe improve their current functioning and get to the highest level as possible. And we don't want any complications. So there's a difference between rehabilitative care and restorative care. So know those definitions as well. And the last one is sarcopenia, which we talked about again in one of the other chapters. This is age-related loss of muscle because there's a decrease in protein synthesis of muscle. You can remember this, as I mentioned, as a sarcomere. Remember the actin and all that sarcomeres that we have with muscles. And so that's how you can remember that, because sarco means muscle. All right, so know that term. You may see that. Not much introduction needs really to be spoken to you about. We do know that because of the many chronic diseases and conditions that a client has, that it is significant, and it can actually cause many of them to become frail and even disabled. And a lot of our older patients have limited mobility. They are dealing with pain. They have difficulties with their communication, their senses. And of course, there's all kinds of risk related to all of those things. And because our people are living much longer now, many of our patients will live much longer in the conditions that they are at. So it's important that we as nurses try to help their patients stay as healthy as possible, as long as possible. And even with age-related changes, we hope that those patients will only have a few years in which their comorbidities and all those other problems with their chronic conditions will only affect them for a few years and not for years and years and years. But unfortunately, it still happens. So we must think about, and I think we all are aware that we can save a lot of lives now, but what is the quality of life? And that is not for us to make that judgment call, but it's something to think about when you're caring for your patients. So rehabilitative services usually come with people who have strokes or maybe a hip replacement, fractures, or maybe a myocardial infarction or some kind of massive trauma. We go to rehabilitative areas. And if patients are on Medicare, generally some of that will provide some of the reimbursement for the cost of being in a rehab program. So again, what we want to do is to make sure that these patients don't get worse than they already are. And if they have any major problems, that we can keep them at least at their current level of functioning. So that's why we want our patients to have some rehabilitation. So restorative care, what's interesting is that it's usually offered by the nursing staff and does not require a medical order. And we can do it at any time. Basically, what it is that we can use our nursing diagnoses and our plans of care to restore that patient to the highest level of wellness of where they were at before they came into the hospital. And so that's what we want to do. Independence, of course. Unfortunately, the clinical state, the patient usually has poor endurance, they're fatigued, they don't move around a lot, they have weak grip. And some of those things that we can do as nurses to help them, teach them range of motion, we can actually help them ambulate, walk. We can do a lot of those things, ambulate with them. So this is restorative care really is something that nurses can do, right? And unfortunately, there are many patients who are frail, as we mentioned in the definition earlier, and there are lots of risk related to the frailty of our older patients. So as nurses, we want to be on top of their condition. So here's a lot of the risk. We've talked a lot about these throughout the entire quarter so far. Respiratory problems and dehydration is very common. Lots of hospitalizations in and out for our really older patients, particularly who are frail. So what we would like to do as nurses is to provide the interventions that we know can actually help them or to keep them from falling or keep them from having a pressure ulcer or injury, and making sure we turn them, making sure they can ambulate to help with that respiratory system, and all of those types of things. So there are lots of risk. Unfortunately, sometimes some of our patients will have to live with some type of disability. And again, if they are disfigured from a fire or they have lost a limb from, say, diabetic condition or from a multiple trauma, it's going to alter the way they look at themselves and their self-esteem. And as they get worse and worse with their disabilities, then death starts to loom over them. And we'll talk about death a little bit later, but there are patients who come into our hospitals who have been lying in a bed for years, maybe from a car wreck, and they've come and they are now in the hospital. They're wind up on special beds. They don't really talk to us very much. Sometimes they can't talk. Maybe they're in like a fetal positioning. So they're living their lives with all these disabilities, and eventually they may die. But sometimes it takes years and years and years of this in and out of the hospital before they finally succumb to the stress and trauma of that disability. Some patients who have disabilities, they talk about pain, emotional pain, of course, and it can be, excuse me, can be very devastating to our patients who have a disability. So we need to keep a very positive attitude, help them cope with the changes that are going in their lives. We want to include the family as much as possible. And of course, whenever someone becomes disabled, they will go through that grief stage, similar to death and dying, because of the loss of, say, the limb or the legs or the inability to see, those types of things. So sometimes they're happy, sometimes they're not happy, they're negative. So it takes a lot of emotional strain on a nurse to be able to help those patients reach the highest level that they can possibly reach. So the whole thing about rehabilitation nurses, and I actually worked in a rehab hospital for a short time as their nurse educator. And it was just amazing to see how the nurses and the therapists work with the patients to get them ready to go back out into the society. We really help them to do a lot of self-care. A lot of occupational therapists worked there to help them learn how to cook again. We had everything from trauma patients to patients who had strokes. So we want to help them be able to care for themselves as much as possible. Because as you remember in psychology, and of course in many of your courses that you've taken here at school, you know that we want them to feel independent as much as possible, and it really helps their self-esteem. Of course, some things that we have to help our patients with, we have to teach them how to use a wheelchair, and how to go up and down the ramps that they might have to have at home. Teaching them how to give injections is another one. We need to teach them about their medications, as we mentioned earlier today, so they can do those range of motions that can keep them from becoming contracted in their limbs. Oh, so many things in the rehab nursing that we will do. If you are interested in rehabilitation for patients, it's a wonderful field to be in. I thoroughly enjoyed it when I was working at the rehab hospital. There is an association for rehabilitation nurses, and there's continuing education and all of those things related to that. So if that's something that interests you, then I have the website there for you. Importantly is that we want to prevent any type of complications as much as we can for our patients, and get them home as quickly as possible or to wherever they're going. Usually many of them did go home. Okay. Things to do know for sure about this particular chapter is how to do a functional assessment. There is an ADL and an IADL, and we're going to look at those. But basically, ADLs are eating and washing, dressing, toileting, moving, mobility, as it says here. So be sure you know the difference between the basic ADLs and your IADLs. So IADLs are beyond the basics. In other words, preparing meals and shopping and using a telephone, safely using medications, knowing how to use their little medication boxes if they have that, how to clean their home if that's something they want to do. We want to see if they can travel in the community. How would they use the bus system or the taxis or other types of transportation, and help them with their managing of finances. That's a whole higher level than your ADLs. ADLs are just basic physiological, Maslow's physiological needs there, eating, hygiene, etc. Now there is a tool, it's the CAT Index of Independence and Activities of Daily Living. And I actually have put it online, I believe, on your Canvas, but also this link will take you right to that. I won't do it today, but basically this particular tool helps to measure whether a patient can bathe, dress, toilet transfer, continence, and feeding. So that's what this particular CAT's index does. It helps to measure those things. So be sure you know the difference between the two. Another tool that we can use is known as SPICES, Fulmer SPICES. Be sure you know this. Fulmer SPICES. It's just simply an acronym that we can use when we're looking at our patients. So if we look at the S, it means sleep disorders. Is the patient having any sleep disorders? Are they having any problems with eating or drinking? Are they incontinent? Are they confused? Is there evidence of falls? And is their skin having a problem with breakdown? Just using this little acronym of SPICES, it helps us as nurses to develop a plan of care to address some of the problems that we're seeing. So you can use this when you're out in clinical and as a nurse as well to get a quick snapshot of your patient's overall health status, particularly for the older patient. And it was designed specifically for the older patient. So it's called Fulmer SPICES. And you can get more detailed information on that link up there at the top. So your nurse is assessing a nutritional status of an older client with a disability, and as part of the assessment, the nurse evaluates the client's ability to perform instrumental activities of daily living. On which IADL would the nurse most likely focus? And so you would going to be selecting all that apply. Somebody want to try that? So what is the IADLs?
Steps past ADLs.
Okay. So it's a lot more than just your basics, right? So which one of these would you choose?
Shopping for groceries.
Okay.
Meal prep.
Okay. Cooking.
And cleaning.
Okay. All right. What do you think about getting around the kitchen?
That would be it.
Okay. Let's take a look. Oops. There you go. So B, C, and D are the best. Getting around the kitchen would be more of a mobility, and that would be under an activity of daily living, the ADLs. So shopping, preparing meals, working on finances, cleaning up after cooking a meal, all of those things. Eating, of course, is one of your ADLs. So again, be sure you know the difference between the two. For interventions to help function, of course, we all know about the proper positioning and about range of motion. But just a reminder for your range of motion, be sure that you're providing support below and above the joints. It's important. Make sure the joints are moving slowly and smoothly. At least 3 times you want to move that joint. And as always, you remember not to force the joint beyond resistance or pain. And of course, we always document. So we have to monitor for some things that would tell us that we need to stop exercising with the patients. If your heart rate gets fast, greater than 100 beats per minute, as at rest, or if their exercise is 35% above the resting heart rate, that might be sometimes we might be overexerting the patient, so we might want to kind of slow down. Any type of physical signs such as angina or symptoms, shortness of breath, coloring, of course, your pallor or your cyanosis, and your dizziness, having difficulty with their gait or coordination, sweating, diaphoresis, lots of confusion and restlessness. So we have to kind of monitor as we are working with our patients, trying to improve their function. We want to make sure that we don't overexert them where they get worse instead of better. Unfortunately, as nurses, we sometimes will interfere with rehabilitation because they will assume the older adult has limitations. Then the nurse will focus on those limitations, and then they will do things for the adult without really finding out, is there a limitation? We're caring profession and we want to always be helping, but keep in mind that the whole purpose of being a nurse is to help the patient reach a level of independence as much as possible. If we hurry a patient during a procedure or during a exercise or trying to get them to eat faster, or become impatient with them, we're actually interfering with their ability to grow and improve their functioning. We're not really supposed to be problem solving for a patient. We want the patient to talk to us, and then we can talk to the patient and see what they say about solving a problem. In other words, if a patient tells you that they're going home in a wheelchair, and they could get around in their kitchen, but it's hard to get around in their living room. We don't want to sit there and start rattling off all these things that we can think about as how to clear the area, make sure there's no cords under the rug, under the rugs to have them get stuck and fall over. So again, we want the patient to try to come up with as many ideas as they can in order to solve that problem. We don't want to solve all their problems. We want them to be very independent and do that. Sometimes, of course, we have to look at those, ambulatory devices. Okay. As a reminder for your canes, always place your cane on the unaffected side. And when the affected limb advances, that's when you would advance. The patient would go forward. So place the cane on unaffected side and advance when the affected limb advances. Be sure you know that. As just a reminder, you've had this before. Walkers, I think the presentation showed some really great pictures that did come out of the textbook, but I really like them. Be sure to get up, place the hands on the sides of the walker, elbows slightly flexed, especially when they're walking with the walker. And then they advance the walker a little bit, and then they step forward. When they sit, they want to back that walker into the seat. And then when they begin to stand, they're going to put their hands on the armrest, but not on the walker, because, the walkers they can easily fall, even tip over. So you have to teach your patients how to use those walkers. And of course, for the wheelchairs, be sure you actually make sure that they understand about checking the brakes. If there's any jagged areas on the wheelchair, like on the seat, sometimes those seats will crack a little bit. That could cut the patient. And remember, the older adult has very fragile skin in some cases. If there's anything broken or there's any missing hardware on the wheelchair. So your mobility aids is very important. Now, we do have lots of physical therapists that help us with this, but as nurses, we may have to teach some of this ourselves. If you are going to be a home health nurse and do some rehabilitation in a home setting, you will probably have to know this as well. It's obvious that you would have to know it. So that's why you learn it as a nurse. So here's a question. Are you going to take care of several older people who need a mobility device? So the nurse determines that the client voicing which statement demonstrates understanding about the proper use of the device. Let's look at each one of those. The first patient says, "My cane helps me stay more balanced and stable when I walk." The second one says, "I'm using a walker to prevent further decline of my mobility." The third patient says, "I use my wheelchair to get around the care facility because I can't walk quickly." And the last one says, "My adjustable cane helps me bear weight on my weak side, so I move from bed to chair." So which one of these would really demonstrate understanding about the proper use?
Is it A?
Okay. Very good. Absolutely. Yes, the cane is basically used for balance and stability. Using a walker does not necessarily prevent further decline of their ability to move. It's just a way that they can able to move. It doesn't necessarily prevent it. And the patient can't walk fast, so they're going to run around in the healthcare facility with their wheelchair. If they can walk slow around the healthcare facility if they don't need that wheelchair, right? And of course, the cane bears weight on my weak side. So they're going to move from the bed to chair. You're always going to put that cane in the strongest side of the patient. So just a quick question as a reminder of some of those important points about the use of mobility aids. Of course, bowel and bladder training is things that we will do sometimes in the long-term care, or excuse me, in the rehabilitative hospitals. And sometimes rehabilitative hospitals are connected to long-term care. Um, but again, we know about incontinence. And the thing is with patients who are learning to control their bowels, they definitely need a lot of praise. I know when I worked at the Spinal and Head Injury Rehabilitative Center, um, for a few years as a young nurse, I do remember that we had to do a lot of bowel and bladder training for our spinal cord injuries. And if they accidentally wet themselves, we didn't make a big fuss about it. But what we did was praise them for being able um, to hold their urine every 4 hours and then let us know that they have to void. So it's really something that we have to be so encouraging to these patients so they will at least try. We should never fuss at them, okay? And we definitely want to have them wear street clothes. We don't let them walk around in their jammies in rehabilitation hospitals because we want them to feel positive about themselves. I toured a hospital. It was a rehab hospital. Where was that at? I think it was in Orlando. Yes, I believe it was either Orlando or Tallahassee when I was working. And it was amazing. And not only do they have the usual occupational therapies place, but they had like little storefronts where they were teaching a patient how to pay for their food, how to go shopping. I mean, it was like built like little stores, um, little kitchens, and it looked so much like a real place. And it gave the patients so much more satisfaction that they're actually feel like they were actually in the community, going to the store and buying clothes and putting their shoes on. And it was really, really a beautiful place. It was unbelievable. I've never seen one quite like that. So some of the rehab facilities are more than just a little physical therapy room and an OT room. Some of them are quite elaborate. And this was one. I can't remember the name of that place. I was impressed. They had cardboard trees. I mean, it looked just like a big little city. It was really cool. All right. Of course, we always have to keep thinking about their mental status. Our older patients can lose some of their mental facilities, particularly after trauma. And so we want to kind of improve upon that. And there's a couple things that we can do. Number one is reminiscing. Basically, it helps the patient to think about what they have done in the past. It helps to improve their memory, obviously, and it really validates them for who they are. Okay, that they were able to lift weights when they were a younger person, and all of those things about reminiscing. Remember, if patients like to reminisce, and our older patients, and it's good because it stimulates the mental facilities that they have. All right, it also helps other people too, but particularly we use this technique when we're taking care of these types of patients. I like the suggestion your book gives about playing old records and having photographs up. It really stimulates. If you have photographs of family members or activities that the patient once did, or old records or even CDs that the patients once used to listen to, that really gets the conversation going about what they were doing at the time when that particular song came out. And then photographs really encourage questions. Oh, where were you at? I mean, our patients are so amazing. They say, oh, where was this taken? And then that conversation can go on. But it causes them to think, and that's really important. Don't forget, our most precious skill that we have as nurses is to listen. Just let them talk. It's okay. We want them to reminisce because we know it's very therapeutic. Of course, reality orientation is another activity that we teach our patients or help our patients with, particularly if they're already confused, maybe they have some disorientation. And it's just simply another way of keeping their mind active. So some things, and your book also brought out some really good things, like besides the date and the weather and what time's your next meal and what's the next holiday, um, clocks and calendars and holiday themed decorations and uh, reality boards and lots of interactions with staff, constantly talking, telling the patient about what's going on today, what's in the newspaper. Um, those things really do help with that reality orientation for our older patients. And we have to be consistent. Every shift has to be the same way. You know, all the nurses have to buy into this and actually help the patient with this reality orientation. I have had patients, family members get really upset because the patient wasn't remembering um, about maybe something that happened 15 years ago or 5 minutes ago, and they get upset. So patients, families, and friends need to be educated as well on the process of this disorientation, or if there's memory loss from some trauma. So we need to teach the patient, as the patient's family and friends as well, not to be upset, not to get mad at the person. Just keep encouraging them, and that's truly what it means. So here is a question in regards to reminiscing. And you're taking care of lots of older patients. The nurse determines that the discussion was successful because she was talking to this group when the staff identifies reminiscence as having which effect. So reminiscent, what is it? Is it for entertainment, validation of existence, resolving past conflicts, finding meaning in life, and memory improvement? Which one of those do you think?
Means of finding meaning in remaining life.
Okay. Anything else?
E.
Did you say B? I'm sorry, did you say B, validation of existence?
E, memory improvement.
Oh, memory improvement. Okay, okay. Let's take a look. All but entertain. Excuse me. All of these really have a lot of value in reminiscing. So that's why we do it. If you've ever had a grandfather, my father himself, I remember visiting him before he passed. He would talk about the things that he had done as a young boy, as a young man, the things that he learned in life, and how he took care of problems that came up. So all of those things are really, really important for helping our older patients. So it is a technique called reminiscing. There's always lots of resources that are in the community, and if you work in a rehabilitation place, then you will learn all those different types of resources. You may have learned some of that when you took public health too, because in public health you do learn about all kinds of resources that are available. So nothing really specifically here. It's just community resources are vitally important for someone who has been in rehabilitation. They need to know what's going on, right, in their community. That will help them. All right, so that's all, just some very short things about rehabilitation. Any questions about this? Okay. Just as a reminder, I put in the CATS Index of Independence on in your modules. You'll see it there, and you probably should read it for your own use as well, because if you ever have to do this, it talks about bathing and dressing and toileting, but it tells how does the patient get a point for independence. And I'll just tell you one, for instance. It's either going to be independence or dependence. And so on a patient for toileting, they will get 1 point if they go to the toilet, get on and off, arranges clothing, and cleans the genital area without help. They'll get a point. However, if they need help for transferring to the toilet, cleaning themselves, or they have to use a bedpan or a commode, they'll get no points. They'll become more dependent. So then what happens, you score these. Very simple. It's very easy to use. And a patient who scores a 6, the patient is very independent. And a 0 means a patient is very dependent. So I think it would be useful for you to take a look at because you may run across that when you're out there in clinical and in your care. Okay. All right. So let's go ahead and go to long-term care. And this is very short as well. I've only pulled certain things out. Can you see my slides okay? Okay, thank you. Somebody responded. I appreciate that. Thank you. So this one is a fairly short, but you're not going to learn a lot about long-term care, but just a couple of things I think are important. I have also worked at long-term care facilities. So I've kind of worked almost everywhere, I think, in my career. And I know that some of you are going out to some long-term care when you had your Gero experiences. So just know that now we're seeing long-term care becoming much more complicated. The patients are sicker and sicker. There's all kinds of levels of care that are in long-term care. And so nurses are becoming much more valued members of the team in long-term care facilities, registered nurses. LPNs, of course, work at many of these long-term care facilities, but sometimes in some of the units, particularly when ventilators are available, then they need the RN as well. If you work in one of these long-term care facilities, you actually begin to feel like these patients are your family because you're around them all the time, and they're not going anywhere. They either die or rarely do they go home, okay? So you really be able to establish a long-term relationship, and you may have noticed that when you were in clinical with these. However, there has been institutionalized care, has got a little stigma attached to it. At the end of the 17th century, these long-term care facilities were for the mentally ill, the disabled, the really old people, maybe some orphans, the very poor, and some of them were suffering from all kinds of contagious diseases. So it was not a very nice place to go. There's a little bit, it has changed, it's become much more positive now. Unfortunately, some of the history that people have heard about the long-term care, and of course, you know, the things that happened during the hurricane a couple of years ago where the patients were dying because they ran out of air conditioning. I think it was in South Florida somewhere, and some of the COVID issues that have gone on now. But that doesn't mean that every long-term care facility is like this. And one thing that you may have learned is that there are report cards for long-term care facilities. And then you can actually go and do some research. If you have to say you have a person that you love, you have to put into a long-term care facility. Do your research. Look at the status. Look at the infection rates. Look at the things that they have. And as we talked about in geriatrics early on about the baby boomers are going to go to places that got that internet, they got a gym, they got all kinds of fun things to do. So again, do your homework and look at that before you have someone committed to a long-term care facility. In the United States, really around the end of the 17th century, it was believed that the aged person should really just stay at home, be cared for at home. And remember, in history of nursing, way back in fundamentals, we talked about the almshouses. They were created in the community, and the only types of nurses that were there in the 18th century or so, 17th century, was prostitutes or people off the street, or even patients themselves would be what we call the nurses. So again, the history of long-term care has been kind of sad, actually. All right. The almshouses, as I mentioned, they didn't have a whole lot of resources, and there wasn't really a lot of money to take care of the residents. And again, as I mentioned, those that recovered from whatever's going on with them, they were expected to work. If they can work, they're going to make them work. They mixed criminals along with the aged and the poor. Patient autonomy is something now that we look at a lot more. You can see the history as things have gotten better. But before the 20th century, patients didn't have a whole lot of say-so about anything. They were just told what to do. They isolated the people, the owners of these facilities. They isolated the patients from everybody else. They were actually treated like inmates rather than as unique individuals like we do today. We have all kinds of recreational activities and things of that nature to help with our long-term care residents. And so back then, the residents did start acting kind of strange. They had some mental health issues as well. And then after a while, they didn't care about anything and they were not active. They were very, very unhealthy. It's a little bit different now. In fact, it's a lot different. For those institutions, everything was very strict. There was inflexible schedules. This is what you do. All the rules were enforced quite viciously at times. And there's lots of rules. And they had activities that helped the institution, not the person. The person was never thought about as being important. So they would do things like plant gardens just so they could feed the people, and the institutions wouldn't have to spend money on food. So those are the kinds of things that were occurring way back then. The patient was not really considered much. In the early 1900s, the institutions began to replace those almshouses that we talked about. And then they were become more dedicated to specific populations. There was very little funding for them. Definitely no assessment of needs. You know, we talk about assessment of needs all the time now. We have to do those assessments. But at that time in the early 1900s, there wasn't any. There was no planning. There was no models for institutional care. Long-term care really was, it was modeled after prisons and hospitals. And of course, the hospitals were terrible back in those early 1900s. And then Social Security came around in about 1935. And some of the small facilities were beginning to be established. Then a little bit of personal care was started to be offered, and then they were going to get a room and board. That's because Social Security was paying for it. So now the people had to pay for their room and board, and it is still today that way. Then the Hill-Burton Act in 1946, there was a huge building boom of hospitals and construction around 1946. And this particular act really designed the hospitals, but the nursing facilities actually followed something very similar. These strict hospital models, and what they were, like no pets. Nurses were wearing starched white uniforms, very rigid, still rigid, even in 1946. The residents were very passive. They really had nothing to, they were not allowed to say anything. And of course, there was very, very strict visitation policies. So it was a rough time in 1946-ish areas. And then in the 60s, we have Medicare and Medicaid. And there it became where, well, they needed more care in these long-term facilities. So the government decided that they were going to reimburse these long-term care facilities using Medicaid and Medicare. However, there was minimal federal oversight. And so the hospitals, or these nursing homes, I should say, long-term care facilities, they just did what they wanted to because the federal government wasn't even hardly involved. They would just pay the money. And so the owners didn't even know how to run a nursing facility. There was no rules and regulations like we see today. That was still in the 1960s, and that has not been that long ago. Okay. And then in 1987, be sure you know the Omnibus Budget Reconciliation Act, known as OBRA. Be sure you know that term. Okay. This was the 20th anniversary of federal legislation that was passed to improve the quality of nursing home care. And what does that all mean? Well, basically, it talks about the state of the nursing homes, what legislation and laws would need to be done, and many, many other things of what has to be done now for our long-term care residents. And so consumer advocates also were very instrumental in the development of nursing home reform. So we started getting a lot of reform and regulations around 1987. And class, that has not been that long ago. I was alive in 1987. I remember 1987, and I never knew I was going to be a nurse in 1987, right? Actually, yeah. So it's kind of like, it's amazing that you are now going to be living through the next 20, 30, 40 years as a nurse, and you're going to see a lot of changes in not just nursing facilities, but in hospitals and how things are run. So lots of changes are coming. But good things happened with the Omnibus Budget Reconciliation. And so now and the other thing that it did is that clinical practice or performance was being monitored and how the care was being given to those older patients in those nursing homes. So what is the lessons your book brings out about from history? Well, we definitely need a new vision for long-term care. Unfortunately, if nurses themselves do not become parts of the leadership, then of course we know who's going to take over and tell us how we're going to practice, and that's going to be those non-nurses, people who don't have an understanding of nursing. And I will tell you that if you're not a nurse, you don't understand nursing. Nursing is such a special profession that even if you're a non-nurse and you think you know nursing, you won't know nursing until you actually become a nurse. And you're probably beginning to realize that now, and you'll see that. So definitely needs a lot of leadership in nursing, okay, to help determine our practice. And of course, that's the state legislature as well, and the federal government. So we do know that if we as nurses, we don't help to correct that problem, whatever's going on in our healthcare system, somebody else is going to do it for us. And it's better that nurses make these decisions because we are in a great position to understand the needs of our population and our people. And sometimes if there's an issue in the healthcare, the systems, sometimes the public think it's all the nurse's fault, or at least part of the problem. Right? So we have seen a lot of upheavals since COVID has come around. It has been an eye-opener for long-term care facilities. It has been an eye-opener for hospitals, for many, many, many issues. So hopefully there'll be some research coming out of all of this, and we will see better healthcare systems as we move forward in our life. Okay. So today, right now, our facilities, nursing homes are really called long-term care facilities. There's lots of federal regulations. Now they have licensed staff and certified nursing assistants, and they're pretty much more regulated now. Don't use as many restraints, obviously. And all those medications, those psychotropic meds that they used to use on patients that would kind of keep them in a state of stupor, basically, to keep them quiet. We don't have that as much anymore. And of course, documentation has become the top priority for not even hospitals, but long-term care facilities. There's still a lot of problems about staffing and funding and all those expectations. However, don't forget, as I mentioned a few minutes ago, the baby boomers are looking for those facilities that are Cadillacs, health foods, internet, all that great stuff that they are used to. And they're going to start demanding it from these long-term care facilities. So, wow, there's so much that's happening in our world, and we can make a difference in these long-term care facilities. They should not be a place, honestly, where old people go and die and left alone. And that's still kind of the perception that we are seeing even today. Just a perception. So there are many types of regulations, federal and state. Remember, we have the Bill of Rights. The residents have their own special rights. We do all kinds of regulations that's related to admissions and transfers and discharges. Nursing services, dietary services are now all involved in the long-term care facilities. Rehab, dental, you name it, they usually have it. Infection control is a big one, and it's even more big now that all this COVID stuff has caused a little bit of upheaval in the care of our patients in the long-term care facilities. All right. And of course, the physical environment. If you walk into a nursing facility and you smell urine, that's not a good sign. You should not walk into a long-term care facility and smell old urine. Okay, because when urine stays on our poor patients, it becomes like ammonia, and you start smelling that. That means something is wrong in the cleanliness of either your patients and also your rooms and stuff. Right. So Florida has ACHA, A-C-H-A. They actually, you could go to their website, ACHA, Florida, and it actually runs or regulates the long-term care facilities and others similar in the state of Florida. They compare hospitals for you, and they compare the nursing facilities as well. If you want to explore all of that information, they talk about the length of stay, readmissions. They're looking at all of these things. They're looking at restraints and hydration and nutrition. So ACHA has some really great comparison charts for all the nursing facilities in the state of Florida. So if that's interesting to you, you might want to go there. I guess I should have put it up here. Okay. Okay. So for your nursing home residents, many residents are incontinent and they are cognitively impaired, as we mentioned earlier, about their pain as well. We have to watch their pain. And how they get around their functional ability really determines the need for what type of long-term care facility they need to go to. And what we find is that caregivers are trying to take care of their families at home. In the old days, remember, they would take care of their family members at home. But now with the families separated by distance, by working, all the people in the house work, nobody's there to take care of the older person. It's a lot harder, and the strain on a caregiver is very, very difficult. So that's why we do see the family can no longer take care of that person. And so they put them in a long-term care facility. And sometimes, I like the last statement there, a crisis typically triggers the need for placement in long-term care or in a nursing home. And that's usually true. If you say you're taking care of someone who has Alzheimer's dementia, and after a while, the person is up most of the night, maybe they can't take care of themselves. They're going to the bathroom every 20 minutes or peeing every 20 minutes. The family cannot handle that because of all the things that are going around in the family. And on top of that, class, think about the Eric Erickson stages. The people that are the middle age, they call that the sandwich generation. And that person in that sandwich generation are the people a lot of times who are taking care of the older person, which becomes an issue because then they're getting, their kids are leaving home, but now they got to take care of an older person. All their dreams and things that they wanted to do are going to be stifled by the fact they're taking care of an older person, and they lose patience. And so some type of crisis usually happens, or maybe the person falls, and that fall can cause, broken hips, cuts in the head, maybe even some neurological problems. And of course, at that point, they tend to start placing them in a nursing home. They go to the hospital, and guess where they go? To a nursing facility. Hopefully not for long, but many times they stay there. Okay, so what are our roles and responsibilities? We definitely need some really competent nurses in the business, right? Especially in the long-term care facilities. Lots of things that gerontological nurses do. We monitor the health status of the patient. You can recommend rehabilitative treatments and restorative care techniques whenever possible. The rehab center that I worked at before, I did work at a rehabilitation center, and we were all part of the team, all the nurses, and we gave our opinions, we gave our observations. There's a lot of camaraderie in those types of facilities. We as nurses have to really be able to notice very subtle changes. Remember all those things we've talked about with the older patient. So that's what we have to do. We have to protect and advocate for the patient's rights. We want to try to promote a high quality of care as much as possible, being sure that the resident has their needs met. And we also, as RNs, nurses, have to really make sure to ensure and promote the competency of the nursing staff, making sure that they're able to do certain tasks, that they're keeping up with their continuing education credits. We monitor residents' health status. A lot of evaluation is coming from the registered nurse and how effective is the care. And we identify any changes early, and we know what to do about it. So gerontological nurses have a huge responsibility working in a long-term care facility. There is an MDS, a minimum data set, which is really a standardized assessment tool provided by the federal government. It's completed on a mission when there's a change in status, or annually. I should say, and annually as well. So it's pretty heavy duty. It's all about if the facility is getting Medicare or Medicaid certified nursing homes, then we have to do that. It's very comprehensive. It includes all the functional capabilities, the health needs, assessments of the patient. And what they did, they want to know more about the patient's comorbidities, their physical, psychological state, psychosocial functioning as well. They want to know all of these things. In addition to that, they want to know all about the other types of treatments, such like hospice care or oxygen therapy, chemotherapy, dialysis, or physical therapy, occupational therapy, speech, restorative nursing. So in other words, what did this patient get? And it's a very detailed requirement. Lots and lots of paperwork involved in long-term care. But for the gerontological nurse who works there, it's definitely a challenge and a very rewarding career, actually. So this statement, of course, is absolutely true. I just mentioned about the minimum data set. It is that standardized tool. A couple of other things, and we'll be done with this chapter. We've heard of assisted living communities and community-based or home health care. Basically, assisted living communities, the patients are not as sick or have as many needs. Their regulations are a little bit less. We don't use as many licensed nurses available. In assisted living communities, and I believe in the state of Florida, there are medication techs. I actually taught a course a few years back to nursing assistants so they can actually give medications. And some of them weren't even nursing assistants. They were able to give those medicines to those patients. So you don't have as many licensed nurses. Of course, more and more people are needing assisted living. And majority of assisted living is private pay. So not a whole lot of people can go to private pay. It's very expensive. And so only a certain group of people can go to these assisted living, although there's others. Okay. There are some challenges for the gerontological nurse. To save money, sometimes the families will put them in assisted living to save money, but they might need a little bit more in-depth care that could be provided by the long-term care facility. So that's a huge challenge in the assisted living. Lots of community-based home health care, and I know you did work public health, so respite care, home-delivered meals, Meals on Wheels, lots of home health agencies. They are booming. Home health agencies are always in need of nurses. It's booming. Now they have home health agencies that are strictly for pediatrics, so if you like pediatrics. And of course, there are some faith-based community programs for particular parishes or churches that also hire nurses as well. So the new model of the long-term care facility really is about holism and healing. Hygiene, holism, and healing is the hierarchy of what the new model of long-term care is looking like. But we as nurses, if you're interested in long-term care, this is where your ideas would be very valuable. The model actually says that psychological and social and spiritual well-being are equal and sometimes even more greater importance than the physical well-being. The caregivers are taught about creating a home-like environment, and the staff assignments are going to be much more consistent. Lots of staff education. They're encouraging nurses to have the very nurturing, positive relationships with the team, with the residents there, and of course, empowering the residents and their caregivers as well. So that's the whole new look of the long-term care. Now here is the 3 levels. This is a model that your book shows us. You have hygiene at the bottom, then you have your holism, and then you have healing at the top. Okay. So just know the 3, but I'm not going to ask you detailed questions on this, but just know that there are lots of changes that are in the making for our home care. Okay. So what I want to do here is show you a video. Let me see if I can get this running correctly. All right. Tell me if you can hear this. It's about 4 minutes long. And the question is, why geriatric nursing? So let me start it.
I really hear it well.
Okay. All right. So what'd you think of that? Does anybody want to be a geriatric nurse? I see some smiles. Yeah. Well, you have to love it. All right, so that's pretty much, there's a couple of questions on that last slide presentation. I'll let you answer them. You can get the answers if you put the slide presentation in the lecture mode. You'll get the answers, just a couple left. The last chapter we're going to talk about is what we call the end-of-life care. Okay, we came back at what time did we come back? 11, 10:40. What time did we come back? 10:45? Okay, oh good, so we have some time. So we're going to go ahead and start with end-of-life care. You're very familiar with end-of-life care. However, there's a few things I just want to point out in this chapter. And I have a little short vignette I'm going to show you when we get to that point, and then we'll be finished the book on geriatrics and gerontology for nurses. Okay, let's do it. Let's go ahead and see what's coming up with this part. Of course, I don't have to say all of this to you. We just know that death is part of living. And so now, many people do not know much about death simply because in the old days, remember, the people would be living at home and they would die at home. People were used to that. Didn't have as many hospitals or other places. But now presently, we notice that there's limited experience with death. We do have some of that in the hospitals, but it has changed over time in how nurses, see death and how people in general see death. Again, most people have very minimal direct involvement with the dying people or dying family members. It's very impersonal in some cases, and it's an unusual event because people are living longer now. There is a lot of difficulty in many populations in which accepting mortality is not easy to take, right? But it's important that all of us understand that mortality is something that is true, and we need to be able to understand it ourselves before we can take care and help families and patients go through that dying process. So we know that patients' reactions to death are influenced by lots of different things and many factors. And I've listed some up here for you. And I do believe you remember the dying individual, such as Elizabeth Kubler-Ross's conceptual framework. You have 5 stages of coping mechanisms with dying. And so we need to understand each of those interventions, and we're going to go over those in just a minute. Okay. But remember also that dying, not all people who die go through the same sequencing of stages. Sometimes they stay longer in one stage than they do in another. So let's look at the stages of grief. What's very important in this chapter is the stages of grief. Okay. Denial. Of course, the stages can be both patients and caregivers. Okay. Denial, the nurse shouldn't argue. We should be very sensitive to the use of denial as a coping mechanism. We should be available and supportive for the second opinion. So remember, as a nurse, we're not going to argue with the patient. We need to be very sensitive about the use of denial as a coping mechanism, and we need to be supportive if the patient wants us to have a second opinion. Then they go through the anger stage, or potentially go through the anger stage. Do not take the anger personally class, all right? It's not really aimed at the nurse. However, it does provide the client with a sense of security, right? They want to have as much control as possible, and as nurses, we need to allow the patient to maintain that control as much as possible. And sometimes as nurses, we need to share our feelings with, say, another colleague or another nurse just so we can get that emotional state under control and just share those feelings and how we feel about this anger problem. The third one is bargaining. We need to be listening, and we just want the patients to share their thoughts and feelings. We just let them do all the talking, and we know that's a very common one where the patient will bargain. And then depression can set in. We should allow that. We want them to express their sorrow, and we need to allow the silence and give them respect, because sometimes the patient just wants to be left alone. So we have to be able to recognize that. Don't try to cheer up the patient, right? Because that only makes it worse. So we don't go in there and jolly and tell the patient, oh, you mustn't be depressed. Okay, that does not cheer up anyone, particularly someone who is dying. Many times when they get to this point, sometimes we do have to get spiritual or religious leaders, which are appropriate for that particular patient, to come and visit these patients. The acceptance stage is where whatever the patient has decided that you need to contact, if they're allowed, if they're still able to, of course, go through the acceptance stage, let them decide. And we want to just make the environment comfortable and pleasant as much as possible, simplify it basically, and provide whatever makes the patient much more happier and support the family as they're going through the stage of grief. So just the basic stages of grief. So let's talk about the grief ball of yarn. Every patient, every person has a different ball of yarn, and some balls are not tightly woven. So let's look at this. To me, this ball of yarn is like my grief, a tightly wadded bunch of conflicting emotions that I can't sort through. It fills me up and it hurts. There's anger and heartache and sadness and even relief. I can't deal with all these at the same time. I am overwhelmed, stunned, and confused. As each grief emotion is sorted and addressed, I evolve to become a different person. My grief doesn't go away because it's part of me, but the chaos and confusion begins to fade. And once each grieving emotion is identified, I can start to unwind them one at a time. I pull out each emotion to reflect and address, and only then can I begin to cope. So this is known as your ball of yarn. Every one of us has a different ball of yarn, and how we pull each one of those emotions out of there and identified is up to the individual person. But eventually it all comes back together, as you can see through this little picture of the yarn. So how can we help our patient? In nursing school, you're prepared to deal with dying, with a dead body. I mean, we teach you postmortem care and all of that. But we need to be more involved in that dying process. We need to be humanistic. If we can have hospice care, that would be very supportive. That's a very powerful tool now to take care of our patients who are dying. And of course, nursing interventions need to be to be individualized, of course. So the hospice nurse really supports the patient and family with a 24-hour availability. They do hands-on care. They provide symptom and pain management, referrals to supportive services, and even resources for home care. They do a lot of that, emotional support. And of course, the nurse also has to be able to ventilate or vent with their own coworkers. They have to be able to close with their patients. There has to be closure when a patient of ours dies. We have to be able to let that patient go. And nurses need to be able to grieve after each death. And sometimes you were with a patient for long periods of time when you're taking care of them, and you become very attached to that person. The hospice nurse is trained and educated in lots of details about how to care for the dying person. And it's also a field of nursing that some people really love. Okay, so you might be interested in hospice nursing. So the older nurse has decided to go to a hospice after being diagnosed, older adult, I'm sorry, has decided to go to a hospice after being diagnosed with a terminal illness. And how can the nurse best provide holistic care in this situation? Should we encourage more chemo, get a second opinion, provide comfort measures, or ask the insurance company to get an extended stay in the hospital? Pretty obviously, the answer is what?
C.
C, yeah. All right. Yes, remember, we're providing the holistic care for patients. However, there are some physical challenges which are important to know. Physical challenge, yeah, lots of them. Lots of things as fear is common, particularly with pain. Pain is the challenge here. So we need to be able to manage their pain. So really the goal to prevent pain rather than treat it when it increases. We want to try to prevent the pain. We should be giving our patients around-the-clock medications for pain medications and have an option for giving pain control whenever they have breakthrough pain. That's important, and the healthcare provider usually will address that as well. So when we keep the pain and we minimize it, it helps to reduce the anxiety of the patient, obviously, and the amount of the medication that they're going to need, of course. All right. Sometimes the patient will develop a tolerance to pain medications, and the dosages may be increased a little bit, and sometimes even going beyond the standard ranges. Sometimes it's necessary. So whatever we can do to decrease their discomfort, we need to provide it. So the first physical care challenge is pain. The second one is respiratory distress. Many problems come along with someone who's dying. Pleural effusion can occur. The patient develops fluids in their lungs. Other blood gases begin to deteriorate. Lots of other respiratory problems in the patient who is dying. So what can we do to help those patients? Think about it. Of course, the head of the bed. Sometimes pacing. If someone is in respiratory distress and they can walk, sometimes they might just want to walk, pace around. Relaxation exercises is also something we can help them with. Oxygen, obviously, is good. Sometimes medications, atropine, furosemide, remember those can help reduce the bronchial secretions. And even narcotics can be used. But respiratory distress can really be both a physical and a psychological problem for our patients. Obviously, they're not going to be eating very well. Most of the time, eating is reduced because they're fatigued or they're weak. They won't want to eat a whole lot. So what can we do? Well, small meals with nice smells is good, and appearance. Actually, an alcoholic drink at this time might boost their appetite. Even though we talk about alcohol all the time, we're talking about a different patient. We're talking about patients who are dying. And so sometimes that alcohol will boost their appetite. We can use antiemetics, but by the way, ginger is really used really nicely for nausea and vomiting. And ginger doesn't have all the side effects of the other antiemetics that we might want to give our patients. Be sure we take care of their oral hygiene. Their room is clean, and there's no unusual, terrible smells. Make it pleasant. Sit with them if they can eat, and help them to eat if it's necessary. But poor nutritional intake because of anorexia, nausea, and vomiting really causes them not to do very well as they are in the process of dying. Physical care, also constipation is a big problem with our older patients as they die. Remember that food is, they may not take as much food or fluids, so of course it's going to lead to constipation, and all the medicines that we give them can also lead to constipation. We do know that the basic interventions would be activity if possible, fluid intake as much as possible, okay, fiber. But watch for that impaction. Excuse me. So we have 4 physical care challenges, but there are spiritual care needs as well. We need to talk with our patients about their spiritual care because they may want to speak to someone. And your book has a quote here: courage is not the absence of fear, it is the ability to act in the face of fear. And dying requires courage. They're not losing their minds. They're just trying to figure out what's going on with this new translation from life to death. And it's disoriented them. And so that's spiritual care is extremely important during this time frame, right? And remember, spirituality is different for all people. So we have to know our patients. What is their understanding of spirituality? And again, be sure we know their cultural expectations. So here's a question. A patient was diagnosed with a terminal illness, and the patient begins to cry. Which response by the nurse would be appropriate to facilitate the client's spiritual health? You think?
B.
Okay. Yes, of course. B. Remember that we can pray as long as the patient will ask us. This up here, will remember that everything in life, even bad things, happens for a reason, is a totally uncomfortable, horrible thing to say to a dying patient, right? And so to ask them, is there anything that's positive at the moment? That only negates the fact that we don't really care that they're dying. So the only answer truly is B. Okay. Of course, we have to think about family and friends and offer that support. All right. So for families, let's talk about the dying process for the family. If a family or friend is in denial, a couple things they might do. They might, say, for instance, discourage the patient from talking about death. They might not visit the patients as frequently as they normally would. They may tell the patient, oh, you'll get better once you get home. They might even try to go and find more doctors for this particular dying patient. So families can be in denial as well. They can be angry. They might criticize the staff and the healthcare providers. Oh, I've seen that a lot. Boy, have I seen that a lot. They yell at the staff. They say bad things. They may even belittle another family member for not taking care of or recognizing the problem that's causing the death of the patient. I've seen that. I sure have. And they might question why death has to happen with this person, of course. So they can become very angry. When they bargain, the family, friends, when they do try to bargain, they will usually do the similar actions that a patient would. So, oh, if you'll just let my sister live until graduation, those types of statements. They can also become depressed, family members. They become dependent on the nursing staff. They might be crying. They're going to limit contact with the patient because they just are depressed about the patient's death. And of course, once they get to the acceptance stage, a family, they do sit down and spend a lot of time reminiscing with the patient, may even bring favorite foods and other objects to remind the patient how their life was before. Sometimes they will just, before they leave the room, I've heard a patient say, a family member say this, when you think that when my brother is almost going to leave us, would you please contact me? I've heard that statement so many times in my career. And it also makes them start thinking about their own death arrangements, like are they going to be cremated? Are they going to get buried? Where are they going to get buried? Do they have a will? Even the families and friends will start thinking like that when they see this. But keep in mind that the patient and the family may not be in the same stage. Okay. Okay, there's a question here. The nurse observes an older client with a terminal illness sitting quietly staring out the window. Which nursing action indicates that the nurse understands how to help the client with a stage of depression? Are you going to suggest the client cheer up? Are you going to help him eat something? Are you going to sit down and hold the client's hand? Are you just going to encourage him to watch TV? Yes, we can sit and hold the client's hand. So that is the best answer for that question. Again, to help families and friends really after a death, they always have a lot of questions. We need to be there for support. And those are just some things that we could do to help with family and friends. All right. An older client with a terminal illness is having difficulty breathing. What action should the nurse take to help this client? Would you restrict their opioids, cluster their activities, administer oxygen, or lower the head of the bed? What do you think? Your patient's having trouble breathing.
Oxygen?
Yes, give them oxygen. It's okay. All right. You know, we always cluster activities if a patient is weak or needs doesn't need to be disturbed. But the question is asking about a breathing problem. So we definitely just going to give them some oxygen. However, don't forget that nurses who are caring for the dead and the death and dying patients need support. Many facilities have support groups. They need to be able to talk about what has happened. Sometimes they need their own spirituality relationships because they have to think about their own mortality. Some of the nurses do not have much experience with death, so it's difficult for them to handle this. Again, that's why we have support. We have to have support. And I have seen on occasion where somebody dies and the nurse blames themselves because the patient died. You mustn't ever do that to yourself, okay? It's not your fault. You've done everything you can. And of course, nurses on occasion will go through those stages of dying as well. A couple of other things. All of us need support, of course, as I mentioned. We need to think about our own issues with death and dying before we actually go out there and become a nurse and start working with death and dying. Be able to acknowledge those feelings. And there's lots of resources that we can use. Okay. So that's really all in this chapter on death and dying. However, I'm going to show you one video. Let me pull my thing here. This is, you've got the link there, but I'm actually going to show you let's see. Can y'all see this? Where I moved it to Divining Hope?
Yes.
Okay, good, good. Okay, this is an excellent, excellent site. It's free. It is produced by Carolyn Jones. You may have heard of her. Again, it's free to all, and there's CE credits assigned. If you want, you're a registered nurse, you can come back to this site. That's why I've given you the site. There's multiple video segments, and they're all about real people who are dying or facing death. And so what I want to show you is video segment 4, which says, I'm here now. And the whole point of this is that sometimes it's difficult to separate ourselves from professional, from a person in our own feelings about a patient or a situation. So let's take a look at it. It's a very short, it's like what, 5 minutes and 56 seconds, so it won't take long, but really watch it and put yourself in the nurse's position. These are real patients. Okay, so I think you will enjoy this.
Professor Stevenson, I can't
Yeah.
hear that. Can anyone else hear it?
Can y'all hear it?
No, there's no sound.
You don't have sound. Oh, no. Okay, because you were able to hear what I did earlier, right? You were able to hear the sound earlier. Nobody said anything. Okay. All right. They can't hear the video. They can't hear it. So if Jose's available, because my time's running out. That was Dr. Haylett. She's going to go see if Jose's here. Yeah, because we were able to listen to the rest of it, so I don't know why the video is not showing. So we'll let Jose come and take a look at that for us. Okay, but anyway, if something happens and you can't, these are available to you. Along with that is like a little study guide, like questions and things, and lots of little segments about people who are dying. And this one is a really, really good one, but there's another one called Sympathy versus Empathy. Remember, we've always talked about empathy and sympathy. So it's a little 4-minute video or vignette, they call them, in reference to what is the difference between sympathy and empathy in taking care of patients. And I think when you have an opportunity, I know you're quite busy now, but later on you have the website that you can go to, and I've given you the instructions. It should not require you to put in a password, but if it does, I gave you the password, but you shouldn't have to. It's free to all nurses. And the woman who developed this documentary herself had cancer, and she fell in love with nurses. Hi, Jose. This is a video from online, and they were able to hear my little video earlier from YouTube, but this is one from online, and I can't seem to get it working. I did.
For you?
Huh?
There's sound playing for you?
Yeah, I hear it in there, but they can't hear it. If we stop sharing and come back, would that make a difference?
Oh, let's go.
Let's see, I don't see the little button that says audio. It used to be there. Hang on, class, we're trying to get it fixed. If not, not to worry, you do have access to this material.
Windows. When you're the what person?
Hmm?
I wonder if that's the problem.
Because we just watched a YouTube video.
Let's see here. That's odd.
Because it used to be like a little button up there.
Yeah, I think it opened it in the web browser instead of in Teams. Like it went to your meeting instead of opening the Teams app.
So if I just leave that and just,
Are you recording it?
yes, they are recording. See? Thanks for your patience, class. We're getting there.
Her to get married, so I just wanted to be special for
Let's
her.
start it back.
The whole week it was raining.
Can you hear now, class?
Yes,
Yeah.
we can.
Oh, great. I don't know what he did, but I'll have to learn from that. Yes, something was hung up.
Yeah, it's
Thank
when you
you.
open the meeting, it opened it in the web browser, not in the app.
Okay. I'll have to. All right. Sorry about that, but
My name is Carmen Hernandez. I'm fighting with this since 97, and then I went to remission, and then it's coming back. I got a lot of good memories, but the most important for me is my kids.
She's always talked about, when I get married. I'm her first daughter to get married, so I just wanted to be special for her. The whole week it was raining, and then that day it was nice, right?
Yeah,
It wasn't nothing like
it
big or
was it
anything.
was it was something that we don't expect to be like that, to be so beautiful, so
Full of love.
it was amazing. 5 months, 6 months, 1 year, I don't care. I'm here now. When I open my eyes and I see through the window and I see the birds and the wind, I don't take life for granted no more.
I've learned a lot through her. The situation has changed a lot. Who we are, who we're gonna be in the future too. Some people don't ever know what this feels like. It's a bad feeling, it's a bad situation, it's a bad experience, but I think it just makes you a stronger person and you learn how to deal with things better, how to cope better, how to be a better human.
You learn to live. You learn to live. I want them, if they remember me, they remember me with joy.
What's been bothering you? What's the matter? What?
Well, I wanted to enjoy my life the life that I got before. Go to the park, go to the theater, restaurant,
Is that with the kids or with the
just be
grandkids?
with my kids.
Those are good times.
I just want somebody with me. That's it. I don't want to be alone.
I don't blame you. I wouldn't want to be alone either if I was going through this. Um, um, I had I have ovarian. I was diagnosed with ovarian cancer in August of 2013. I was never sick, no symptoms, energy, still working out. I felt great, and I had a whole hysterectomy, and they told me, yeah, you have metastatic ovarian cancer stage 3. And I was up on my unit, and there was a mother. She was 34 years old. She was a Muslim woman. She was a lovely woman, and she has this ovarian cancer metastatic, and there she died. And there goes her kids behind the cart that took her away. And all of us, I mean, all of us just like bawled. I said, oh my God, it's going to be me. You don't have 2 kids.
I have to cry at least one time in a day.
Yeah, we all do. You're no different than anybody. We're all going to cry. We're going to cry with you. It's normal. It's okay. You're a real strong lady.
No,
I think so. I think
I
you're doing
have
pretty
to.
good.
I have to because I don't want my kids to suffer more. I love them to death.
Amanda, yeah, I can tell you're in pain too. You want time? I do. I remember being so sick. I was hooked everywhere. I had a tube everywhere. I'm thinking, is this what people go through? Now I can see why people turn around and say, you know what? I'm good. I was treated for 9 months, 8 months, feels like forever. And I'm cured. So they say I'm cured, but it comes back. So they asked me at one point, if you can't take chemotherapy anymore, what is it you want to do? And I told my doctor, I said, listen, this is not going to work. I've already told my family, don't let me suffer.
Okay, so I wanted to show you this because as you go out there and to become a nurse, you're actually going to understand that something in your life may trigger these types of emotions. In the case of the RN there, she actually had the metastatic ovarian cancer. This woman was dying from cancer, and she had already taken care of another woman who had cancer. And so sometimes you have to think about, how would you deal with this? How would you deal with this if there's something that's triggering your own emotions? What do you think you might do? Have you ever thought about it? Okay.
I
Right,
take a time. I take a time out, and
okay.
sometimes, I mean, it has to be in a way so that I'm not skipping on my responsibility, but it's worked in the past. I can usually get somebody to cover for me, or, I just excuse myself for a moment. Usually I find a short walk takes care of it. And then I'm
Okay.
back in duty.
Okay. That's a really good point. Taking time away. Is it okay to cry with your patients?
Yes.
Sure. Yeah, obviously, she was crying and she was feeling uh, poorly for her patient there. But always remember that there are going to be some support systems that will help you as a nurse as you go out there to become that nurse. There's lots of support groups. There's some individual counseling you might be able to get. The employee health services might have something that would be able to help you at the hospitals. Of course, yoga and exercise, those types of things, stress relief activities, that's also a good one. Even socializing with your colleagues away from work to laugh and talk. Debriefing, you're familiar with debriefing. You do that after your simulation. That might be something after one of your patients is very ill and passes away. You might want to do some of those types of things. Take some time for yourself. But when Diane, her name was Diane, when she was talking to Mrs. Hernandez, they're both crying. So do you think that Diane's own situation contributed in some way to her empathy for her patient? Yes. Yes, because she has been through something very similar and she almost died from her cancer. So what I'm going to do now, I just wanted you to see that these vignettes are excellent. And there's, I think, eight of those. So you have the site. I won't show any more because I want to do your review. But I want you to know that they're there for you if you would like to see some of those. Please feel free to use it. And when you get that RN and you need some CEUs, you can always go there and also do that. Okay. So we've talked about a whole lot of stuff. Let me find my material. We've talked a whole lot of stuff this last 6 weeks in nursing in this course. Okay. And what I'm doing now is I'm going to be looking for, I have some notes here. Let me kind of come back to you because I want you to be able to see me. All right. So I'm going to escape from that. All right. There we go. Let me get out of there. I want to stop sharing so we can get you woken up. Yeah, for sure. All right. Let me stop sharing. Okay. Here we go. Okay. Okay. All right, so are you ready? Feel free to take notes. So your exam 3 information review, let me just talk about the things that you have learned. Real quick.
Quick
Yes?
question.
Sure.
Is it okay, like in a situation like that, to say to a patient, I need to step out for a moment and I'll be right back? Is that like not finishing with my responsibility, or is it going to make the patient feel like not interested, or is that something that is reasonable to do? Because I've heard that it is from supervisors that I've had in the past, and also during classes, that it's okay. So I just wanted to hear what your view is in a situation like that where a person gets, because that happened to me during sim when I was on the hospice sim, and I stepped out for a minute and came back and I was fine. And it didn't seem that they felt that that was inappropriate, is what I'm saying.
Mm-hmm. No, I have no problem with that either. I think it's okay. A little bit of crying with a patient is one thing, but if the emotions of what has happened in the past overtake the nurse's professional responsibilities, then it would really be more detrimental to the patient. So you could ask them that you have to step out for just a moment, and you go do what you need to do. And then when you come back, sometimes the patient will ask you, how are you doing? I mean, sometimes they'll actually start a conversation up. But yes, it is okay. I totally agree with your supervisors. Yep. Yeah. Did that answer your question? Okay, sure.
Yeah.
All right. Okay, sure. Okay, as a reminder, class, be sure to take a look at Chapter 5, even though it's not listed on your syllabus. But if you want a review of some of the age-related changes, it's in Chapter 5 of your textbook. A very, very, very clear cut, and that's what those are. But we've covered pain and mental health things and reproductive, a few things on male and female reproduction, some cancer, of course, the acute care, the different types of tools for a long-term care facility, and of course in death and dying. So let me just kind of give you a few concepts that you'd be sure that you are familiar with. Types of pain is the first one. Be sure you know the different types of pain. There's some definitions that I had mentioned, like neuropathic, nociceptive pain, persistent pain. Those are some terms. I know the difference between nociceptive and neuropathic pain. Okay. Another one that's important to remember is box 13.1. Signs that could indicate pain in persons with cognitive impairments. Remember, that's like grimacing and crying and perspiration and splinting. Remember, these are patients who are not able to talk with you. So that's an important box to review. Medications that we have talked about as well, your acetaminophen, your NSAIDs, and your opioids. I remember the WHO, the review of the 3 tiers. We usually start with acetaminophen. This was under pain and comfort chapter. Acetaminophen is the most commonly used for the older adults. Of course, ibuprofen is best for bone and muscle pain. And then, of course, opioids are really, really good as well. But remember, Darvocet, propoxyphene, and pentazocine are contraindicated with the older adults. And so there's 3 examples there, and there's 3 levels of those. Today we talked about death and dying. Ginger, we talked about ginger as a really, really great natural substance that can help with nausea and vomiting. And it's things that we would like to do. And some of the basic nursing measures, how can you take care of someone who has got the issues of nausea and dying, vomiting during the dying phase. As far as some pathophysiology or some physiology, make sure you understand about the liver, what it can do, what it's used for. Remember, the liver does decrease in size as the patient ages. Right? And there's some issues with that, and of course, it's going to affect those drugs. Aspirin, again, I'm going back to aspirin. Bleeding and delayed clotting time from aspirin, so we have to really look for some bleeding concerns. Salicylic toxicity, important. Dizziness, vomiting, tinnitus, hearing loss, some sweating and fever. So that's all from aspirin. We've mentioned a lot about acetaminophen already, but just as a reminder that even acetaminophen can cause false results with some blood glucose tests, so we got to watch that. If a patient already has those renal or liver problems, then of course acetaminophen can become very toxic. So the daily dose of acetaminophen should not exceed 4,000 milligrams. That's the high dose. For long term, because it will cause irreversible hepatic cirrhosis. So no more than 4,000 milligrams a day is what we should do. Okay. A little bit about acetaminophen.
What will it cause?
I'm sorry?
What will it cause again?
Oh, hepatic necrosis. In other words, the liver will start to die. Okay. Absolutely. So not more than 4,000. We talked about digitalis, and I actually said that that's an important drug. Be sure you're checking those potassium levels with that, and watch for digitalis toxicity. And what lab results would I be concerned about specifically for dig? Which electrolyte would I be worrying about?
Potassium for hypokalemia.
Hypokalemia, very good, Kiyomi, excellent. Because remember, it sensitizes the heart to the effects of digitalis. So watch that. Whenever you're doing your medication review, we mentioned it today. Remember those, like, why is the drug was ordered, and is it the smallest amount of dosage? Those, I think there was like 5 or 6 of those things that we talked about. So when you're doing a medication review, you want to ask yourself that. Don't forget ginkgo biloba causes blood clotting, right? So we need to watch with that. For some of the reproductive concerns that we might have is vaginitis, all right? And why vaginitis occurs. So be sure you're looking at the physiology of that, of why somebody, a woman would have developed vaginitis. And some of the ways that we can help that, we might put a topical steroid cream on the patient, make sure that they have cleanliness and those types of things. All right, so that would be something that would help with that vaginitis. Because remember, the vagina is very fragile as they get older. Cervical cancer. Pain does not usually occur in cervical cancer. Vaginal bleeding and leukorrhea are signs of cervical cancer, but there's usually no pain. All right. Unfortunately, the treatment has to be radiation and surgery. We mentioned perineal herniation. This is where the cystocele occur, the prolapsed uterus, and it's very much more common when patients have more than one children, like they multiparous. It causes a lot of weakening of the perineal wall, and so that's why they see more of the rectoceles and the cystoceles in that population. Again, the bladder, if you have bladder tumors and things, we might have painless hematuria. You might see that. There's no evidence. Remember we talked about some of the myths about cancer. Caffeine may cause cancer. You've heard of that, but remember, that's a myth. There's no really any evidence that caffeine causes cancer. All right, important. BPH. Take a look at BPH. If a patient has severe pain in their back and they're a patient with benign prostatic hyperplasia, you can betcha he's probably got metastasis, because then they get a lot of acute pain. Initially, the benign prostatic hyperplasia is not painful, but if it's cancerous and it metastasizes, then they're going to have some really acute back pain. So think about how that occurs with their patient. And if a patient does have their prostate removed, they need to be checked. Prostate surgery, they need to be checked every 6 months or so. The men need to go in to make sure that that increased tissue on that prostate has not become cancerous. So they need every 6 months checkups. Aging on the skin. What are the effects of aging on the skin? I think y'all can come up with some of those. Be sure you know that. Some A&P, please be sure that you, and I mentioned already chapter 5, just review that material. Where's the pituitary gland? What does it do? What kind of hormones is it in it? There's a anterior and the posterior. Don't forget your thyroid gland. Just kind of review the A&P and your physiology there. Some more things about skin. Stasis dermatitis. Y'all remember what that means? What is stasis dermatitis?
Dermatitis from the blood not flowing.
Absolutely, and we tend to see that in venous problems, right? The lower legs of the patient will get all kind of brown colored. They'll look brownish. They'll start developing lots of itching, and they could lead to stasis ulcers. So stasis dermatitis is a skin condition to be aware of. How to assess a mole using your ABCDs. The term cautious in relationship to skin problems. Signs of hypo and hyperglycemia. All right. So the glycosylated HG levels, the A1C, the HgA1C, what is the time frame for that? What does that tell us about the patient's sugar responses? What is it? Why do we do the A1C?
Make sure they're managing their disease.
Yes, they're managing their disease, and usually it's about a 6 to 12 week time frame it looks at. 7%. You want to be below 7%. Cognitive assessment levels, page 429 and 430 in your textbook. The assessment of cognitive levels. There's some interview questions that are really good. We're going to assess things like orientation and memory, judgment, calculations, the 3-stage command they call it. All right. Or comprehension is what we also call it. You give the patient 3 things, pick up the cup, put it on the table, and bring me a fork. So that's a 3-stage command of comprehension, making sure the patient understands that, of course. All right.
Can you repeat the page numbers, please?
429 and 430. And there's some interview ones there too. Mental health, delirium, and dementia. Please make sure you know the difference between the two. On the PowerPoint slide that's up there, it actually shows you, but in the textbook it's really clear as well. Metoprolol, it's a beta blocker, will aggravate depression. Okay. The antidepressant medications, remember we start low and go slow. And at the beginning of treatment with antidepressants, remember they can become kind of sedated, so they have a high fall risk with those antidepressants. How do you manage mental health behaviors? How do you deal with those behaviors? How do you base someone who has dementia? Right, very important. It's all about taking care of those patients, managing it. That, of course, a little bit about suicide, the symptoms of an alcohol disorder. Remember, there's a box. I mentioned it to you when we talked about it. There's a little box. I didn't put the page number down here, but it gives you the signs and symptoms of an alcohol disorder. Be sure you take a look. The role of a gerontological nurse, we talked about that today. What do we do? There's a whole list that I put on my PowerPoint for you. How to use walkers and canes. We mentioned the ADLs and the IADLs today, very important to know. The Omnibus Budget Reconciliation Act, which we talked about today, right? There's a new model of long-term care, holism and healing. A couple of assessment tools to review is the Fulmer Spices. Okay, that's an assessment tool. There was I think it's under cancer, but it was a discussion of, no, it's in acute care. And the acute care chapter talked about the surgical patient and what happens to the older person after surgery. So be sure you are recognizing signs of hypoxia. Remember, they become really, really restless. They can get confused easily, the patients, the older patients. Of course, we talked just a few minutes ago about death and dying, how to comfort someone who's going through this process, how to care for that patient through that process, and the family, and the stages of grief. And what are some of the nursing interventions that you can do for those stages of grief? All right, so it gives you some things to think about. All right. So any questions about anything? Tomorrow, let's see, what's the day? Tuesday, Thursday. Thursday, you'll have your exam. It'll be the same as your usual exam, 70 questions, maybe 5 or so of calculations. All right. It'll be your third and final exam. There'll be no cumulative exam. The only thing cumulative about this exam is I mentioned that you've got to remember your age-related changes. That's really the key in gerontology, understanding and being able to understand the physiology and the anatomy and those age-related changes. So any more questions about anything? Y'all are very quiet today. Yeah, and I understand. This is our last day together. I'm going to miss you. I'm going to see you on Thursday for the exam, but I won't have you in this class. I'll see you tomorrow for sure in senior seminar. So we'll be working together tomorrow with your ATIs. I truly have enjoyed teaching you and talking with you about gerontology. As your book does state, we cannot get away from gerontology. It's out there, and we're all taking care of gerontology patients, honestly, in the hospital. They're not all those youngsters, are they? Okay. So if you don't have any questions, reminder about the Defining Hope. It's really, really a good set of videos that you might be interested in at some point in your career. So you might want to save that, the web link, because it's really, really good. It's excellent. They're actually coming out of another movie. I think she's doing emergency trauma, and The American Nurse was also another one of her documentaries, Carolyn Jones. So very, very famous person who loves nurses, and she's not a nurse. Okay. If there is no other questions, thank you again for allowing me to be here in your class. Of course, I'm still available to you at all times if you need anything. All right. And I wish you the best of luck on that IV test today. Y'all got this, right? You got this. Yeah, you do. You've got this. You're fixing to go out to clinical.